Hello everyone. Today I am going to discuss about pulmonary hypertension. Often in lung diseases or cardiac disorder cases, when we get echocardiography, we will see sometimes it will be mentioned that there is pulmonary hypertension. So majority of the times we will overlook this condition. You might be knowing the sentence of grade 1 diastolic dysfunction or grade 1 fatty liver in ultrasound. So these are some sentences during investigations which we often overlook. Especially this pulmonary hypertension, majority of the times is considered as an extension or the consequence of lung disease, long-standing lung diseases or cardiac conditions. It is not true. This particular topic is a separate entity itself and it has its own pathogenesis, clinical features, way of management. All things are different when it comes to pulmonary hypertension. So we will discuss in detail about this topic today. So main source for this video is from Harrison, chapter number 294. So we will be discussing what is the meaning, what are the etiology for this particular condition, what are different classes which are often asked during rounds and viva, and how to evaluate and manage the case of pulmonary hypertension. Coming to the definition or meaning as such, we will just compare this pulmonary hypertension with the well-known systemic hypertension, which all of us are very well versed. So we will keep on comparing pulmonary circulation changes with the systemic circulation so that it will be very easier. So the meaning is increased pressures and increased resistance to the blood flow in pulmonary circulation is nothing but pulmonary hypertension. So if we focus on this particular image, mainly this will be right atrium, right ventricle. From here the outlet will be pulmonary artery. So it will divide into branches, and once it is in the pulmonary area, it will again get divided into pulmonary arterioles. So these are the arterioles and then capillaries as the normal division of any particular vessel. Then there will be gas exchange happening at the level of capillaries. After the exchange, there will be venules which will combine to form vein. That is nothing but pulmonary vein, which will carry oxygenated blood to the left atrium. From there again left ventricle, and it will be circulated throughout the body. This particular segment all of us are knowing. So whatever is there in the red is related to systemic circulation, right? But our topic is related to pulmonary circulation. So what we are saying according to the definition, increased pressure in the pulmonary circulation, starting from pulmonary artery, the division, arterioles, capillaries, even the tools, etc. So there will be increased pressure and increased resistance to the blood flow. This is the meaning. Then whenever we think of pulmonary hypertension, there are some numericals to be remembered. We know that in systemic circulation, normally the pressure will be considered as 120/80, right? That is nothing but blood pressure. So when we compare with the pulmonary circulation, this pulmonary circulation is a low pressure and low resistance circulation when it is compared with systemic one. So low pressure in the sense, usually the pulmonary arterial pressure should be, pulmonary arterial pressure in the sense it is mean, that is the average of systolic and diastolic. Mean pulmonary arterial pressure should be less than 15 always. This is the first important point. In the sense, if we compare here, it should be 1/8, not more than that. So 1/8 of the systemic circulation. Such a low pressure system it is, and it is a low resistance system. So when we will consider it as hypertension is when the mean pulmonary arterial pressure is more than 20. Previously it was 25. Now they have reduced it to 20 so that we can detect the cases earlier and we can intervene for better outcome. Then there is something called as pulmonary vascular resistance. As mentioned in the definition, the resistance. So previously it was considered if it was more than 3 Wood units. So the units are Wood units. Now it has been reduced to, even if it is more than 2, we consider as increased pulmonary vascular resistance. Then one more value to remember is pulmonary capillary wedge pressure. So PCWP, if it is more than 15, again it is very significant. And if we take only arterial pressure, that is pulmonary artery systolic pressure of more than 35 is again an abnormal value. So these are some numbers which we have to remember. Just explain all of these with the previous diagram. See, here if we consider pulmonary artery, right? Pulmonary artery. So what we are telling, whenever the RV pumps blood into the pulmonary artery, if the systolic pressure here, systolic pressure is more than 35, it is significant. If we take the mean pulmonary artery pressure, here only we are discussing still, if it is more than 20, it is significant. Then we say pulmonary vascular resistance. So just remember, in systemic circulation, whenever we think of systemic circulation, resistance like the peripheral resistance is offered mainly by the arterioles, right? Arterioles. But here in pulmonary circulation, it is mainly by the capillaries. So the value of pulmonary vascular resistance, that is the resistance offered mainly by the capillaries, if it crosses more than 2 Wood units, it is significant. Then one more value which we told in the numericals is pulmonary capillary wedge pressure. Wedge pressure in the sense, like you will understand it later, but to tell it shortly, when we block the flow in the pulmonary capillaries, right, we create a wedge, that is blockage, then we will measure the pressure on the other side. This pressure is nothing but the pressure in the left atrium, that is called as pulmonary capillary wedge pressure. So if it is more than 15, it is significant. Hope you have understood the point. So 2 points from pulmonary artery itself. One is at the center, that is resistance. One more is beyond the capillaries, right? Why we are spending so much time in understanding these pressures is because, see, whatever the segment which is before this capillaries is called as pre-capillary, and whatever is beyond this is post-capillary. So the pre-capillary, any changes, the deciding factor will be these pressures, that is the mean pulmonary arterial pressure will decide that. Whereas in post-capillary, the deciding factor is pulmonary capillary wedge pressure, that is nothing but left atrial pressure reflection. So these are the things. And what about the PVR, that is resistance? This resistance is what? If we go back to the physics, resistance is equal to change in the pressure by flow, right? This was the formula. So here it is nothing but change in the pressure in the sense pressure from pre-capillary to post-capillary. So if we consider pre-capillary pressure 15 as normal, as mentioned earlier, and on the post-capillary side, the left atrial normal pressure, if we take it as 5, right? And the normal flow even in the pulmonary circulation will be just, for example, 5 liter per minute, right? Just like systemic circulation. So it will be 10 by 5 is equal to 2. So this is the resistance, pulmonary vascular resistance. In normal situation, if we take all these numericals, it will be up to 2. So if it is more than 2, we consider as increased resistance. So these are some values to decide. Okay. Next is the reason for all these changes. What might be the reasons? So we again have to compare it with the systemic circulation. That is what? In systemic hypertension, we divide the etiology into essential and secondary hypertension, right? Here also, similar thing is applied. We mainly divide the etiology into primary and secondary. In primary, majority of the times, we consider the reasons as idiopathic, just like systemic hypertension, right? But there is a forum, that is World Symposium on Pulmonary Hypertension. So they have labeled this group 1 as pulmonary arterial hypertension. Here, one point to stress is many people will use the terms pulmonary hypertension and pulmonary arterial hypertension interchangeably, but it is not true. There are some classes of pulmonary hypertension like 1 to 5. Class 1 is purely called as pulmonary arterial hypertension. So this particular term is a subclass of pulmonary hypertension and it is not that common. So this is the difference we have to know. Okay, now when it comes to primary pulmonary hypertension, that is nothing but pulmonary arterial hypertension, which we call. Here mainly the reason will be idiopathic. Then there might be hereditary reason. Mainly there is a gene that is called as BMPR2 gene mutation. So this point is very important, that is bone morphogenic protein receptor 2. So this gene mutation will lead to pulmonary arterial hypertension, and there are some other reasons to develop this class 1 pulmonary hypertension. For example, connective tissue diseases, HIV infection, portal hypertension like liver disease, congenital heart diseases, schistosomiasis. So all these, due to several mechanisms which we are going to discuss in the next slides, will lead to increase in the pressure in pulmonary circulation, right? This is class 1 according to World Symposium on Pulmonary Hypertension. The next class, all these are considered as secondary. So here comes class 2 is mainly because of left heart diseases like any heart failure with preserved EF or reduced EF because of MI or any other reason. Then valvular heart diseases, mainly left-sided valvular heart diseases like mitral valve disorders or aortic valve disorders. And if there are any congenital or acquired cardiovascular conditions, overall, if pulmonary hypertension develops secondary to cardiac disorders, it is class 2. And class 3 is just like class 2. Only thing is, if we develop secondary to lung diseases, which we commonly see in our hospital settings like COPD leading to pulmonary hypertension or restrictive lung diseases, other like mixed varieties can also lead to such things, hypoxia. For example, long-standing illnesses of lungs or those who stay in the high altitude can have long-standing hypoxia leading to pulmonary hypertension. So even we can consider sleep-related disorders like OSA, obstructive sleep apnea leading to pulmonary hypertension will also be considered in class 3 itself. So this is secondary to lung diseases. So these two are very, very common. So if we ask commonest cause or etiology for pulmonary hypertension, answer will be either due to left heart disease or lung diseases. And the class 1 is quite rare. Coming to class 4, it is mainly because of chronic thromboembolism in the pulmonary circulation. We know that many of the times the minor clots or embolus, for example, gas embolus or minor fat embolisms, even the clot per se, will be flowing through the pulmonary circulation, right? So pulmonary circulation, what it will do, it will filter out all such clots. So minor clots will keep on depositing because of filtration in the pulmonary circulation. So over long run, it might lead to obstruction of the flow in pulmonary circulation, leading to pulmonary hypertension. So that particular segment is given as class 4. So in short, they call it as CTEPH, chronic thromboembolism related pulmonary hypertension. That is class 4. Class 5 is miscellaneous if it is because of some other reasons which are not enlisted in the above 4 classes. For example, hematological disorders like sickle cell anemia related pulmonary hypertension, systemic and metabolic disorders related changes like sarcoidosis related hypertension, pulmonary hypertension, etc. are included in class 5. So this is very, very commonly asked question about the classes of pulmonary hypertension. Hope you got the point. Then now we got to know the reasons. Now what will be the pathological changes which will be there in the pulmonary circulation leading to all these pressure changes? Mainly there will be imbalance between two things. One is proliferative and anti-proliferative signals in the lung vasculature. That is, there will be increased proliferation and decreased anti-proliferative signals, leading to what? Excessive cellular proliferation, mainly in the vasculature. Then there will be fibrotic remodeling of the vasculature. Then there will be excessive deposition of the extracellular matrix around the vessels. This is first imbalance. Coming to the second one, again there is a imbalance between vasodilators and vasoconstrictors. For example, it might be because of endothelial dysfunction or nitric oxide synthase dysfunction. These will lead to what? Increased vasoconstrictors and fall in vasodilators, leading to overall vasoconstriction, again increasing the pressure. So this is one more imbalance. Overall, all these things will lead to what? Stiffening of the blood vessels in pulmonary circulation. So this is the overall pathophysiology seen in pulmonary hypertension. So as just now I have mentioned, if we observe a healthy pulmonary artery, arteries will be healthy, flexible, and blood flows very easily. As mentioned, it is a low resistance system, right? When pulmonary hypertension starts developing, initially there will be thick and stiff arterial walls which will limit blood flow and increase the resistance. Here we can easily make out. This was the lumen, this entire lumen. Here it is slowly getting narrowed, right? So lumen is getting narrowed, and if you focus on the surrounding layers like media, intima, and the adventitia, these are all increasing in the thickness. So these changes we can see as the disease advances, like moderate, severe pulmonary hypertension. Lumen narrows, blood flow is restricted because the artery gets narrowed and the surrounding layers will be thickened and stiff. In severe, we can see these plexiform lesions, plexiform vascular lesions. So in the sense, there will be abnormal dilatation and that particular segment will not contract and properly. So because of this, there will be stasis of blood leading to thrombus formation. So these are the hallmark changes, plexiform lesions in the pulmonary circulation. So these are the changes which are seen in pulmonary hypertension. So because of the increased pressure in circulation, what will be the manifestation? How these individuals will present? The main problem is the symptoms of pulmonary hypertension are very non-specific. In the sense, they will overlap with some other conditions. So we will be not thinking of pulmonary hypertension as an isolated condition. This is the major problem. So if we enlist the clinical features, it might be chest pain, D for dyspnea, E for edema, there might be fatigue or giddiness pre-syncope, and one more important observation is what? Happy hypoxia. In the sense, patients will be having low saturation, but even then there might not be any dyspnea or discomfort to the patient. So this is considered as happy hypoxia. Commonly we see in casualties, these COPD individuals will present to casualty with slight dyspnea or cough or some other reason. If we check the saturation at room air, it will be almost 30%, 40 or 50% like that, very low, but still it will not be reflected or it will not be matching with their presentation. And in these cases, if we supplement even minor flow of oxygen like 2 liters or 4 liter, saturation will improve drastically. Like it will reach 90, 94% with very minor flow of oxygen. So this is the hallmark feature which you have to remember when you see such cases in emergency. These are some clinical features. So what will be the consequence of increased resistance or pressures in the pulmonary circulation? Overall, it will lead to excessive load on the right ventricle. So there will be eventual right ventricular failure. So what are the features of right ventricular failure? There will be raised JVP, pedal edema, loud second heart sound, parasternal heave, and there might be holosystolic tricuspid regurgitation murmur. These are some features which we have to look for clinically whenever we think of pulmonary hypertension. Not just depending on the investigations like echo. Always, whenever you get a case of COPD, long-standing hypoxic individuals or left heart failure, whatever, always check for these features clinically. Now, how to investigate? Remember, the gold standard investigation for detecting pulmonary hypertension is right heart catheterization. So overall, we are saying pressure is increased. So we have to prove it. We have to pass the catheter in the right side of the chambers of the heart, and we have to measure the pressure. If it is increased above the given normal thresholds, it is nothing but pulmonary hypertension. So in these pictures, we can see they have passed a catheter from the major vessel like central veins into the right atrium first. They will keep on pushing it, right ventricle, from here pulmonary artery. So here, whenever the catheter is in all these chambers, there will be changes in the pressure, right? So that change is transmitted into a liquid media and it will be read as a pressure change parameter using some monitors. This is what is shown in the image. So they can measure pulmonary arterial pressures, which we told that first when right ventricle contracts, they will measure systolic, PASP. If it is more than 35, it is significant. Then they will take mean pulmonary arterial pressure. If it is more than 20, it is considered as pulmonary hypertension. So these two things, they have got it done here. Then they will still pass the catheter further, and at the division of pulmonary artery, they will block the flow. So they will create a wedge, right? So they will create the wedge and they will measure the pressure changes after blocking the flow. This will give us pulmonary capillary wedge pressure. Again, if it is more than 15, it is important for us. Then using these pressure changes and the normal blood flow, we can get vascular resistance. If it is more than 2, it is significant for pulmonary hypertension. So this is the gold standard investigation which they will do. Some other investigations in relation to pulmonary hypertension are, commonly you might have heard about 6-minute walk test. So in this one, the individuals are asked to walk in an open ground for a duration of 6 minutes. In that, we will be monitoring their saturation changes and heart rate changes or any symptoms changes. So based on this, we can decide whether the individual is having significant fall in the saturation when we consider this test. Then comes chest X-ray, which we often get it done. This will help in 2 ways. One, to find out any chronic lung disorders leading to pulmonary hypertension. The other utilization is the hallmark features of pulmonary hypertension in X-ray. So here in Harrison, they have mentioned. Here, if we focus, whenever there is pulmonary hypertension, after this aortic knuckle, there will be convex prominent mark of pulmonary artery. So this will be very, very prominent. This is first thing. Then if you observe, right side descending pulmonary artery will be thickened. Like usually they will say it should be like a little finger. If the width is increased to more than 20 mm, they will say 20 mm, we can consider it as pulmonary hypertension. And one more point is, it will end abruptly, like abrupt end we can easily make out when we trace the pulmonary artery trunk. And sometimes there will be pruning of the distal vessels, which is also considered as because of increased pressure in the overall system. So these are some changes which you have to observe. When we get the lateral X-ray, the retrosternal space will be obliterated. That is the hallmark of right ventricular enlargement. So these are seen in X-ray. When we get the ECG, there will be right ventricular strain. So here we can make it out. V1, V2, V3, T waves are inverted. So this is again indicator of RV strain. This pattern commonly we will see. And if we get the echo, there will be dilatation of chambers. Mainly right ventricle, right atrium are dilated commonly. Then what is the importance of sleep study? In these individuals, there will be nocturnal hypoxia which can be detected by using sleep study, or if the individual is having OSA, in that case also this will help us. Then comes VQ scan, that is ventilation perfusion scan. Mainly 2 phases are done here. One, these are all nuclear scans, mainly nuclear scans. So in first part, the agent will be inspired. They will take the pictures of the areas where this particular nuclear agent is getting ventilated. That is first one. Same thing, they will inject a nuclear agent into the blood vessels and look for the uptake in the pulmonary circulation. So overall, ventilation and circulation, any mismatch they will observe. Then we can get HIV testing, ANA profile done to find out the cause. As mentioned, HIV might be one of the reason for class 1 pulmonary hypertension. Similarly, some connective tissue diseases might be the reason. So to know the reasons, we can get these tests done. And when it comes to class 4, which I have mentioned, because of chronic thromboembolisms, we can get pulmonary angio. One more segment related to pulmonary hypertension, in particular pulmonary arterial hypertension, that is class 1 specifically, is vasoreactivity test. So in this one, the individuals will be undergoing a test in which they will be asked to inhale either nitric oxide or prostacyclin. So there will be passage of catheter and we measure the baseline pressures, right? Baseline pressure. Then the individual is asked to inhale these gases, nitric oxide or prostacyclin. So after inhalation, there should be a fall of mean pulmonary arterial pressure by more than 10. This one they will measure. If there is fall, in the sense the pressure is responding to the vasodilators like nitric oxide. So this is the group which is considered as responders. If there is no fall in the pressure, they are non-responders. Why is it important? These responders are benefited by giving calcium channel blockers. So these drugs will help in the group which are responding very well to this test. This is nothing but vasoreactivity test, mainly done for idiopathic and hereditary pulmonary arterial hypertension. Coming to the treatment proper, just remember the classes, 5 classes. So first decide the class, accordingly treat the cause. For example, if the reason is class 2, so there are some left-sided heart related issues which we have to focus upon. If it is class 3, so some lung disease is causing pulmonary hypertension, so we have to focus upon that. If class 4, chronic thromboembolism is the reason, so they have to be on anticoagulant therapy lifelong, anticoagulants, and there are some other treatments which we are going to discuss. Like that, try to fix the reason first. Along with this, supplemental oxygen is very, very important. As I mentioned, there will be happy hypoxia in these individuals. So always advise them for LTOT, long-term oxygenation therapy in home or wherever it is possible. So these are the basic steps not to forget. What about the class 1 pulmonary arterial hypertension? So this class is evaluated and studied elaboratively. So they have come up with multiple therapies, multiple treatments. For example, we can use prostaglandins like prostanoids. For example, epoprostinol, treprostinil, prostacyclin, etc. These will be available in inhalation forms, oral form, even injectable forms. And they will mainly target the vasodilation and anti-proliferation. If you remember, there were some imbalances in pathophysiology. So they will target those particular pathological issues by causing vasodilation and anti-proliferation. So these can be used in class 1. And one more important point is these inhaled forms can be utilized in class 3 pulmonary hypertension too. This is one more advantage of prostanoids. Then comes the commonest one, endothelin receptor antagonists. For example, bosentan, ambrisentan, macitentan, etc. So they will focus mainly for inhibition of vasoconstriction, which will release the pressure. Also inhibition of vascular smooth muscle mitosis. So there will be again anti-proliferative action. Anti-proliferation. Same mechanism just like the prostanoids. So these are again available in oral forms. Dosage is mentioned here. These are some examples. Coming to the one which will act through nitric oxide release. So obviously nitric oxide release will lead to vasodilation. Commonest examples are phosphodiesterase 5 inhibitors. Among them, sildenafil, like we can start with 20 mg 3 times daily up to a maximum dose of 80 mg 3 times a day. Then long acting forms like tadalafil. So these are given just OD 40 mg, that will be sufficient. Similarly, one more medication which will act through nitric oxide release is ARASU-MEDPEDS. So this one again 0.5 mg TID we can initiate, and we can go up to 2.5 mg TID as maximum dosage. And this particular drug is also helpful in class 4 pulmonary hypertension, that is nothing but chronic thromboembolism related pulmonary hypertension. So this is one more specialty. Okay, coming to class 4, which I had mentioned, there are some therapies which we have to consider. One is lifelong anticoagulation, preferably warfarin. Other modalities are pulmonary thromboendarterectomy procedure can be done, or balloon angioplasty can be considered, and sometimes even after the procedure, if pulmonary hypertension persists, then the choice of therapy should be ARASU-MEDPEDS. Some newer therapies which are mentioned again in the chapter are sotatercept. So this will act mainly through inhibiting activin signals. So activin signal inhibition will lead to inhibition of the TGF beta. So that will lead to anti-fibrosis in the sense anti-proliferative action. So this is the newer modality of treatment which have been mentioned in the ARASU. Coming to the survival rate, what will be the survival rate even in optimally treated cases? Remember, the 1 year survival rate is 84%, 3 year it will be 67%, by 5 year survival rate fall to 58%. That's why pulmonary hypertension is a condition not to overlook. And whenever we are treating with all these things, what should be our goal? It should be to improve 6-minute walking to at least more than 450 or 500 meters. This should be our target. So whenever we are treating, or we have started on the initial dosage of certain medications like combination and all will start, in that case during follow we have to ask the individual to do a 6-minute walk. In that they should be able to improve it till more than 500 meters or 440 meters. Otherwise we can keep on increasing the dosage till maximum dose. Thank you so much. Hope you got the point about this particular chapter. For more such elaborated understanding of medical concepts, please subscribe to our channel, and if you find this particular video helpful, share it among your friends so that even they will get the advantage of this particular segment. Thank you again. See you in next video.